On today's episode of Sam Talks Telehealth, I'm speaking with Dr. Tony Stearns from iRxReminder. Tony is an expert in the senior care and aging technology space, and he's got such a thoughtful way of thinking about the ways we can use tech with the senior population and also to be able to use tech for mental health and really having better mental health sustainability with our medication. So, without further ado, let's dig right into the podcast. Hey, Tony, welcome to the show. I'm so excited you're here today.
I'm excited to be here.
Awesome. Okay, so I'm really excited to dig in. You do age tech, all these different kinds of things, but give me a brief, information about yourself so my audience knows who you are and the kinds of things that you're up to.
Sure. Well, I guess my chief role is as the chief executive officer of iRxReminder, which is a company that is commercializing a technology built around an Internet of Things pill dispenser, an app, and a cloud that does medication management, really training people to take their medications on time. We're focused in the mental health space today. I also moonlight as a business professor. My training is in industrial organizational psychology. And then I also have a background as an engineer. So that's, I guess my major community activities are led by my role as Secretary General of the International Society of Geron Technology, which is how I'm engaged in aging technologies, aging focused technologies.
I love that. And we had some conversations. So one thing that you've talked about, you use the words social prosthetic and cognitive prosthetic. Can you talk to us a little bit about what that is and what that means?
Sure. So it's probably been 15 years now that we've began work with Cameron Camp and who had brought the idea that we could apply Montessori methods to work in the dementia space. So we worked on we wanted to develop a really easily deployable activity that would be highly engaging to people with dementia. So we developed ultimately a program called the Memory Magic Program, which is a cognitive intervention therapy. And essentially it's sort of like a word bingo game with a plastic board with windows that you pull down when you see the word. And it was built around this cognitive task where you have like a stimuli, which is a fill in the blank stimuli, like Tom, Dick, and blank. So it might be for those of you who don't know, it's Harry. And so you have to be, that's a good example of maybe someone who would be, less than 30 to have no idea what I'm talking about. But if you were over 40 or so, you would know instantly about this movie from the 70s and the expression. So anyways, that fill in the blank, finding the word would be a low cognitive task. So you find the word Harry on the board, pull the window down. Knowing the answer to the riddle, so to speak, is the second level. And then we might have a conversation like, does anyone here at the table know someone named Tom? And one of my best experiences I ever had was we were training a group of relatives to help learn how to play this game, because it's a way of getting a lot of this memories without being any of the pressure of like, do you remember my wedding? I don't know who you are, so no, but it's your daughter, right? Like that's a horrible thing that happens in dementia. But if so this gentleman's son was named Tom, and so the person looked at this person with dementia and said, do you know anyone named Tom? And we had trained her to just wait, and he like processed for a really long time, like 20 seconds, which seems forever. And then he finally said, my father. And the aide looked really disappointed because he didn't say his son, who was sitting right next to him. And you look over at his son and he is beaming. And he goes, no, that's fantastic. I'm named after my grandfather,
Oh,
which always chokes me up a bit.
yeah, because it's so special, right? And
Yeah.
that's what I love when we talked about that technology, because caregivers and family members, it's challenging to see them struggle in that way. And so that you've designed these things that find the folds or the circuitry that is there by using these different associations, I think is fascinating.
Yeah. So it using the long-term memory, these familiar phrases from your youth, the ability to read, all these match well with the things that remain from in dementia. So you have a great scaffolding on which to draw on if you can lay the right tarp over it or the right floorboards to walk across. And that's what all the technology, so to speak, built into this seemingly simple word bingo game becomes really meaningful. The staff also have like cohort knowledge that we've given them to be able to speak to those issues. So like we can give them the first line to How High the Moon, which is a song that everyone 80 and 90 will be able to sing around the table. You won't have any idea, but if you start in on the words, by the light or whatever, it'll begin. Well, that's By the Light of the Silvery Moon. That's not How High the Moon, but okay.
That's so cool. I absolutely love that. And so that one's called, that's Magic Memory. What is that called?
The Memory Magic program.
Memory Magic.
MemoryMagic.com. You can used in many facilities really throughout the world now. But
I love that. I love that. Now let's flip over to the iRx. And when we had talked about it in this behavioral health space, what's fascinating is, we see, like, I think we all know around different kinds of time medications or medication dispensers. And then we know the side of the house of the medical side of the house of remote patient monitoring. But when we talk about mental health and meds, obviously we know they're incredibly important, that those are tied together. And so tell me a little bit about how could we use iRx in this sort of RPM mentality of meds, mental health, and monitoring people.
Yeah. So first of all, the Internet of Things pill dispenser device that I call a pod, so that pill dispensing device, PDD, pod. The pod is really designed to train you to take your medications on time. So it should improve self-management, and our studies have shown that it does. And the way that works is we utilize a dosing window, so that when you, at the beginning of the dosing window, the pod light comes on. I have one here.
Oh yeah, let's see.
This is the pod.
Okay.
So when it's time to take the medication, the light comes on like that. Hopefully you can see that.
Yep, I can.
When you do that, you take the medication, you hold place and tilt it on your hand, and then the pod shuts down and you're done for the day, and it creates a record that is shared with the electronic health record. But if you're forgetting, that's when you get an alert to your smartphone or your smartwatch or your smart speaker in the corner, and it reminds you. And only when you're completely missing your medications is an intervention triggered. And what happens is we create an intelligent action list that is added to the record that is shared with the practice managers, and then they can decide to intervene. And that leads to more revenue and better engagement. So we help the patient be trained to take their medications on time. We help the staff to be aware that there's an issue with not taking their medications that's relatively effortless for them. And then the agency gains more revenue from the additional activities of keeping patients engaged, because normally they're losing about 25% of their patients to disengagement.
Yeah, so we talked about, let's stop there for a second, make sure the audience, because you and I had talked before. So this is specific in behavioral health organizations, and tell us a little bit about that 25% attrition rate. What does that mean for behavioral health organizations? Why is it important?
Yeah, so 25% of patients are disengaging from treatment. Usually, people who stop taking their medications are most at risk for this. So if we imagine someone with bipolar disorder not taking their medications, then that leads to less stable behaviors that might lead to problems with employment or housing or some of these other things. But the idea is that if we know that you haven't taken the medication, it might lead to a social worker visit and a discussion, so that I'm trying to be in a relationship with someone. I need more emotional range. So to get that, I stopped taking my medications, but like, let's renegotiate when and how and the kind of medication that we're taking, so that you can have more emotional range, but still not be out of control. So those kinds of, that invites a discussion that leads to continued engagement. So
Yeah,
that's the idea.
I love that. And I think it's really important, because I certainly in behavioral health, I mean, my audience knows there's bipolar throughout my family. So I've watched my family come on and off meds, and it's really a challenge there. And so I think oftentimes when we think about med management and healthcare, we're so focused on the medical side, right? Like, is the heart failure patient taking theirs, or is the older patient taking theirs, which of course is all very important. But we know with major mental illnesses, it takes so long to get you to the right place that then if you're not taking it, instability, jobs, things like that you mentioned. So I love that this intervention is really focused in that mental health space. A short break in today's podcast to talk to you about more resources for your telehealth services. I've got the Telehealth Toolkit, and that's a great resource with checklists for your video visit setup, the team, your dream team that you'll work with, technology considerations when you're thinking about what you're going to create for your services. And then I also bring you through a really deep dive into the workflow redesign. So the Telehealth Toolkit is simple checklists to be able to really take you through what you need for your telehealth easy setup, and being able to quickly get on camera with the same confidence that you have in your in-person clinics. You can find the Telehealth Toolkit at www.telehealtheasy.com/toolkit. Now with that, let's get back to the podcast. And what do you see? Because, mental health organizations can often be, different funding paths. There can be a lot of bureaucracy, the way things are folded down through the organizations. Like, when you're approaching them, how do you help them see that even if there's tight budgets or things that are difficult, the value of something like this for their clients and patients?
Well, we focus on the value for the agency, actually.
Okay.
So that the value for the patient is that they're going to achieve a high adherence, and if they're taking their meds, we'll know. But for the agency, they're expecting, they're only realizing, let's say, in an agency the size of about 4,000 patients, active patients, they're going to be they're expecting to make around $21 million per year. But because of dropout and staff turnover, which is also at a generally high rate, that they're going to only earn about 14 million. So that 14 million leaves 7 million on the table for that agency. But with what we say is that, well, we'll help keep those patients engaged. But in addition to that, we're going to trigger a whole set of interventions and other activities like monthly medication monitoring and med reviews that will that are all billable activities that can then go on and lead to 24 million in revenue for that agency. So with exactly the same people, they're doing better for patient outcomes and they're gaining more revenue. And in fact, because the staff is intervening and not bringing someone out of crisis, but just like a 30-minute conversation about an alteration to their medication regimen, then everything's going to be great. They're going to feel very satisfied by that.
Right. So it's not only about the patients and the revenue, but reducing the staffing turnover, because staff doesn't feel so like in crisis mode and they're not able to achieve. And what we also know is, You leave one behavioral health organization, you go to another one that's unlikely to be a magic one that's operating so much better, right? We know we have a lot of dysfunction in those operational areas.
Yeah, the way I think about it, or through our discovery interviews over the last few years, is that you're expecting to come out of, say, as a licensed social worker with 20 patients, 20 people on your roster that you can visit everybody every week for the time you're allowed to bill for. But what happens is you end up with 60 people because somebody just left. And so they're splitting, you get extra people. So now you're only seeing people every 3 weeks. So that means that someone who needs more visiting than that is going to fall off into crisis, and you're not going to know it. And then when you finally discover that they didn't show up for their appointment, now you're going to try and help them get back in, and say that takes 5 hours of your time. Well, that's 5 people that you can't help that week. And now they're into the week 4. And that just keeps happening. Eventually, you have so many people in crisis, you feel very liable for that. And so you pick up and start over, where at least you have a clean slate. I think that's kind of how I understand that to be happening. If people could comment on whether they think that's a valid statement or not. But I think that's how it sort of works. But with our system, you know who's doing well. So you can devote a certain amount of your day to helping people, but as a touch point, because you want to stay in touch and make sure everything's okay. But you really have a lot more time to help the people who are about to go into crisis, because you can be informed, and it really changes just the whole nature of the practice. In the same way that story I was telling about Tom, the staff then suddenly knows, oh, that gentleman who doesn't recognize his son still remembers stuff. He remembers his father's name, for example. So he's still in there somewhere. So I'm gonna treat him more like a person. Right.
Yeah,
so it's
that
like a big
tears
leap.
me up. Yeah, because that's what it's about, right? Is how do we humanize humans who are in these various states of crisis, whether it's your mental health crisis, whether it's dementia, declining, all these things. Yeah, we can become, and I don't think anyone in healthcare means to, but when you're exposed to all this all the time, we can go into sort of autopilot also as humans. And every time we humanize someone, it brings us back to that care mindset.
Yeah, it's very different to be the fireman and bringing the person out of the smoking building safe, as opposed to needing them to go to the hospital, right? Like that's sort of the degree of difference. If we can intervene early enough, then we stop a lot of bad things from happening, and that those things weigh on the first responder as well.
Right.
If we
exactly.
stick with the metaphor.
Exactly. That is super interesting. Okay, my last question, which I always like to ask all my guests, is if you could change one thing in healthcare, what would you change?
Yeah, I think I think that the answer to that is, I think I've seen that change happen over the course of when I started. When I first started with the very old school phones that had terrible screens, and email was like Pine, and they were really just like 2 different devices in one phone. I had a hard time convincing researchers that older adults could use these phones, grant funding organizations, and so I believe that we've turned a corner in that area, and people no longer think that like no one over 40 can use a smartphone, which was sort of the opinion of NIH review committees 20 years ago. So that's one thing that I think, and then really like the silver lining of the pandemic for me, and trust me, there was a lot of harm in the pandemic, but it opened up telemedicine in a way where no one was willing to do it, and now it's standard procedure, and that was at least 80% of the hurdles that I faced in iRxReminder, because without sort of an understanding that telemedicine was possible, this enhancement to telemedicine made no sense to anybody.
I love that. I hadn't thought about it that way, obviously, as another person a long time in here and the change in the pandemic, but I hadn't thought about that, how, yeah, with iRxReminder, it allows people to go, oh, I can see how this half works. Now I can actually see how this other half works. Whereas before, if you're scared of telemedicine, the last thing you're going to do is add, another thing that's remote. They don't even understand, like, how would that be possible? No one would be able to do that. Oh, I love that. Okay, where can people go to find you online?
iRxReminder.com is one place, and then I guess I'm listed through the International Society of Gerontechnology. We have our World Congress is coming up. They're biannual, so this year we'll be in Korea. We're hoping that the pandemic will allow Korea to be open, but we have a hybrid conference planned. But if you want to learn about aging technology from the best practitioners in the world, from all over, then the International Society for Gerontechnology is a great place to engage with.
Awesome. So I will put all those notes in the show notes, all those links in the show notes for everybody. Tony, thank you so much for joining me here today. It's really fun to talk to you, and I love to see someone also who's working in a space where I think that not only mental health, but gerontology is super exciting and important work that you're doing. So thank you so much for being here today.
Thanks, Sam.
And I hope you've enjoyed today's episode of Sam Talks Telehealth as much as I have. Don't forget to subscribe and like the podcast. That way you know when the new ones are dropped. And for all of those who want to learn more about telehealth, more resources, and have a chance to work with me directly, feel free to go to telehealtheasy.com, where you can find all the online courses and specialized services that I offer. We'll see you back here next time.